HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Dr. Dinukshi Daniels on dental sleep medicine. Dr. Daniels, tell us about yourself.
Sure. So I've been a dentist now for 18 years. I've worked in general practice for most of that time. In the last 18 months, almost 2 years, I've been working for the Australasian Sleep Association. They've just launched something called the Fellow of Dental Sleep Medicine, which is a certification program which is designed to help dentists who are very well versed in sleep disorders, help them get recognized by their medical colleagues. And so when if you're looking for a dentist to refer to, this you'll be looking for dentists with these FDSM credentials after their name. So I've been managing that program for the last 18 months. They only launched it last year, so it's in the very early stages. We've actually launched it internationally now. So we're getting dentists from all around, at the moment, Southeast Asia, but hopefully the rest of the world soon. So that's what I do currently and who I am.
That's actually really interesting because I understand that dentists have been involved in the sleep medicine sphere for a long time. And what you're doing is that you're formalizing the credentialing of dentists with an interest, I guess, to ensure that a particular standard is met. Is that right?
That's right. And also just to help both patients and GPs and sleep physicians find a suitably qualified dentist. It doesn't mean that if you don't have the FDSM credentials, you're not qualified, because like I said, it's a very new program. It's just for if you're looking for a dentist, you get a patient coming in, you diagnose that they've got sleep apnea, or a sleep physician does, and you're looking for a dentist to refer to, this would be a place to start. That said, if you get a referral from a dentist saying, I've taken an OSA 50 and they've got a score of this, or they've done this sleep study, and that you can tell that they know a thing or two, it's fine to refer back to them as well. It's just, but if you don't have a dentist to refer to, it's a great place to go to.
Thank you, Dinu. I think that's an important resource that GPs will keep in mind. Now, let's go back one step. We did mention dentists having had a diagnosis of sleep apnea, so maybe we can help our GP listeners by presenting a case and walking through that case. So I'm going to just present a hypothetical gentleman. He's 56. He's obese. He's got, say, a BMI of about 34. And of course, as usual, he's been complaining he's been tired in the daytime, falling asleep on the couch. His wife says he snores big time and he chokes. Now, the GP has gone ahead and we've done a sleep study. Surprisingly, his sleep apnea is reported in the mild to moderate range, and that a CPAP device has been recommended or advised. Now, most times we would just go ahead with that recommendation for a CPAP. Do patients like this actually become reasonable candidates for a dental appliance?
In that range, in that slightly more obese range, it does become a bit more difficult. So the way the devices work is they're designed to open up the pharyngeal airway, because that's what's collapsing during obstructive sleep apnea. So these things are made out of nylon and acrylic, or nylon or acrylic. So you're expecting a little bit of nylon or acrylic to move a certain mass forward. Now, the smaller the mass, the better the result.
Gotcha.
So when it comes to sleep apnea, it's a combined effort from us and our GP colleagues, because if they don't make a concentrated effort to reduce that BMI and it just gets worse and worse, there's only so much that acrylic and nylon can do. It's not a silver bullet. It's not you do this and continue on with your lifestyle of bad eating and not exercising and it'll all be well. It's not the way it works. But if there is a combined effort where we're telling them, look, this will hopefully help you get a bit of a better night's sleep, and that will help you have more energy in the day. Now, if you invest that energy into exercising, walk 10 minutes, and then the next month, walk 20 minutes, and just slowly making those small changes along with dietary changes and lifestyle changes. If we're giving them that message and you're giving them that message, there's a chance that it could work. That said, in like that obese range, we usually would recommend try CPAP first. And if and when you hate it, then we can look at an alternative because we have to be realistic. CPAP is still the gold standard. We're not going to pretend that we've got a better option. It's just very poorly tolerated because obviously they can't move around. And if you don't use it, it's not going to work. So usually our recommendation for that type of patient is try CPAP. If you absolutely hate it and you want to try something different, try this. But either way, you're going to have to work on changing that BMI, changing your lifestyle, and then we have a chance.
I was being cheeky. I was actually presenting to you a patient that I knew may not be a good candidate, but it does also show my lack of knowledge about exactly what the device is. And you keep talking about how we need to cooperate together. And of course, everything is a cooperation. But what are we actually cooperating about? How do we learn about each other's roles and therefore can describe how a sleep dental specialist can help us? So maybe the first thing I will give over to you is, what do you guys do as a dental sleep medical person? What is it that you specialize in?
So our role in this whole area is to help them breathe better in their sleep. So CPAP will do that. Like I said, very low compliance. So the other option is to open up their airway instead of forcing air pressure into their oxygen into their lungs. We open up the airway and let them breathe a little bit better. So the device, what it does is it advances your mandible, literally pulls it forward and holds it in position. And that way it opens up the airway to some degree and allows them to breathe better. So there's lower AHI. So that, during AHI is the apnea hypopnea index, the number of times they stop breathing or just have a reduction. So that is the goal for us in what we do. Now, like I said, if they have, what we're trying to do is create a positive feedback loop. So right now, a patient with sleep apnea that's not being treated has a negative feedback loop. They get poor sleep. That means they have less energy in the day. They don't have the energy to exercise or cook a healthy meal and blah, blah, blah. Therefore, they put on weight and then they get even worse sleep as the days and months go by. So what we're trying to do is change that. So we're trying to open up their airway through these devices, open up their pharyngeal airway so they can breathe better. The goal is that they get just a better night's sleep, not the best, but just better, a lower AHI. And usually patients, we might do the test, like the PSG test or a sleep study and find that it's not like the AHI has gone down to 0, but it's less than it was. And that's a noticeable change for the patient. The patient wakes up feeling a little bit more energized. And what we have to do in working together is we have to tell them, now put that energy into something that's going to help you get an even better night's sleep. Put that energy into exercise and put that energy into cooking a better meal for yourself, something that's healthy. That way the device can work better. So over time, that device has got a lighter mass to try and pull forward. Therefore, it can work better. And then you get more energy. Do you know what I mean? So now we turn it into a positive feedback.
I hear that very clearly because you know how much energy and how much educational time has gone into recommending and teaching us how to achieve lifestyle change. So we've been through that area a lot. And so I do agree that giving them a bit more energy may actually help them do that. But what I have heard previously was that there are certain types of patient phenotype that are less likely to respond. And therefore, as GPs, my question would be, whom are best to respond and who are less likely to respond to a jaw advancement splint? So maybe I'll give you that question.
So it can be related to their actual jaw positions. So if they've got a certain position of jaw where we can't actually advance it too much because they're already quite advanced, they're quite protruded, that might mean that they're less likely to respond. In those cases, we usually, if we find a type of patients where we feel we don't really have much movement here, we can't really move their jaw forward, so it's not going to make a huge difference, we might tell them, look, it's not likely to respond as well as we'd like. Why don't you try the CPAP and use this as a backup if it fails? Because both of these options are still more tolerated by patients than surgery, because that's obviously, your third option. So it's usually a fine line between saying, just go down the CPAP route or go down the.
Now, as a GP, two questions come to mind. So if I have a patient with a past history of TMJ dysfunction, we know they're less likely to be able to probably put their mandible forwards. But if I was to look at the patient sideways and I'm seeing if they are suitable, how far forward should they be able to protrude their jaw or their mandible before we think it is that they're suitable or not?
That's something that we take the measurements in our clinic for that. It's one of those things where you look at them and you go, oh yeah, it's going to be, they've got about 5-6 millimeters worth of movement, and you take it and they've got 2 or they've got 10. It's not something that we can even we can't look and tell. It's there's a lot going on in the TMJ in that area. So, and that's why we need to actually get them in the chair and we take the measurement. We see how much range of movement they have before we can work on a device.
So I'm actually hearing from you that you can receive patients for assessment, and then you will tell the patients and the GP whether the patient is suitable or not, and that we as GPs don't need to do that kind of examination ourselves.
Yeah, usually we go by either the GP or the sleep physician's recommendation that they try this. So the recommendations we get are more based on if it's a mild to moderate case as opposed to severe, which really doesn't work well with these devices. So we wait for the recommendation because we can't look at a patient and go, oh yeah, this is going to be the best option, because there's a lot to a sleep study, and probably gone into the different types of sleep studies and whatnot. So we can just see the symptoms. Okay, you're snoring, you're feeling tired during the day, all those kind of things, and refer them to you. You then do the sleep study or refer them to the sleep physician, and based on those findings, usually we will get a recommendation, usually from the sleep physician, to do CPAP or a mandibular advancement splint, and then patient chooses and then comes to us. So those things, and then when they come to us, then we again have to do proper measurements to decide if it's suitable or not.
I have seen some of my reports. The sleep physicians that I have sent patients to have not yet recommended a jaw advancement splint as much as they have a CPAP. And so if they did recommend it, it's room for discussions between GP and patients. If the report doesn't state it specifically, and the patient is not obese, and they do not have severe sleep apnea, is it an appropriate scenario where a GP says, actually, whilst the CPAP remains the gold standard, there may be another treatment that you may need to think about? Is that the time that we bring this up for discussion?
I'd probably get, if the sleep physician has not recommended a splint, because we really do need that recommendation.
Okay.
More for healthcare rebate benefits.
Okay.
Probably wait to maybe get them to try the CPAP. And like I said, because the compliance is so low, patients tend to come back and go, I can't sleep with this thing on my face. And that's when you'd say, let me talk to the sleep physician. Let's see if we can, because we really do need that. Sometimes health plans ask to see that in writing.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
So I'm going to go back and try and summarize this, Dina. So a patient with suspected sleep apnea has been investigated. The report comes back from the sleep physician. Two things happen. One, if they did not specifically mention a jaw advancement splint, you're stuck in the sense that if the specialist did not recommend it, the patients may not get a rebate for the splint from the health fund. Number two, if it was recommended, at least we can have that discussion and the patients can choose. If they choose the gold standard, the CPAP, they may not be able to use it well nor tolerate it. And that is when it is highly appropriate to bring up the discussion for a jaw advancement splint.
Or sometimes patients might, from the start, say, I don't want to sleep with this noisy thing next to me, because there's a lot to a CPAP. It's great in terms of it works, but it's very cumbersome, very loud, the person sleeping next to them might be, okay, snoring's gone, but now I've got a CPAP to contend with. So it might be something that you give them as an option. You've got option A, option B. And I guess with both options, you'd have to talk through because when they're talking to you, they'd be talking through their options, talk to them about the pros and cons of both of them. And sometimes it's a combined treatment. So they might wear the CPAP for part of the night, and then when they get sick of it, they'll take it off and put the splint in. That's also an option, or wearing them together. So wearing the mandibular advancement and having CPAP. So there's options for, just because you buy the CPAP and don't use it that well, doesn't mean you have to throw it away. You can see if it works better in combination or together, all sorts of things.
I have never heard that, That's a really, really good thing to think about, isn't it? And I've certainly never heard of it being used together. So what findings have you got about using both together?
I haven't got the papers on me, but I know that that is an option. And because it's a gold standard and some patients, want to do the best that they can, and then they struggle with it, that might be something. And I guess it's all about telling patients these options. What I have found in the studies is because CPAP has low compliance, the results overall are the same for the mild to moderate cases between the splints and the CPAP. It's not that the splints work as well as the CPAP, they're just worn by more patients for more hours during the night. So the results are very similar. And then for the patients who want to go that extra mile, like I said, a combination would work, either, half or together. So there's a lot of options to talk through. And I think that's the thing. If you talk through these things with the patient when they come to us, what we don't want is the patient coming to us thinking that this is going to solve all their problems and all they have to do is wear it and everything goes back to normal. That's what we don't want. So we need that discussion before they come to us, because we will have that discussion, but they need to hear it a couple of times.
Wow.
You know what I mean?
I'm getting it now. You're really saying before we refer, we need to make sure they understand that there's a difference between how long and well one can use a device versus how effective it is. And while CPAP is highly effective, it may not be well tolerated nor used right through the night, and therefore it makes it probably equally as effective as a device that is not as effective but can be used through the night. And the important thing is the device itself doesn't completely solve your problem. What is incredibly important is that we all work together with you to help you lose the weight, do some exercise, and eat the right food, because all these things are just as important.
Exactly right. Yes. And I guess the thing is, sometimes you need to hear that message, not just from, if they hear it from dentists, people generally think, what do you know? You're a dentist, you just work with teeth. So hearing it from a GP first, who they respect in terms of dietary advice and whatnot, really helps us. Because then if we reiterate that message, then they're like, okay, I understand. And what I usually like to refer to is things like diabetes. Like, you can't just take diabetic meds and eat all the wrong foods and not exercise and think your diabetes is going to get better. And it's a lifelong condition. So that understanding of, okay, this is a whole lifestyle change, and this is just one part of it. That's really important.
You just made me realize I never do a very important practical point in my referral to a sleep physician, Dina. If I had included a paragraph that said, if Jack is found to have mild to moderate OSA, would you think he is also a candidate for the use of a jaw advancement splint? So having asked a question, I expect the physician should answer the question, because if he does, and he says, yes, he is also a candidate, suddenly Jack also becomes eligible for a potential rebate for his splint if he cannot tolerate his CPAP, correct?
Yeah, that'd be great, because then we're all talking the same language.
Gotcha. Okay. That is actually a really important practical point, that GPs who refer patients for a sleep study should write into their referral the consideration of a jaw advancement splint if appropriate.
Yeah, that would be really helpful for us too.
I'm learning new things all the time, Dina. It's wonderful. Okay, so how much does it cost?
So that varies from clinic to clinic. It's really hard to put a price. I would say in the ballpark of 2,000 to 3,000. That's where you'd want, but that's roughly what CPAP costs, I believe. So, but that, like I said, varies. So I wouldn't really tell the patients the price. I'd just say, probably talk to your dentist about it, or talk to whichever dentist you refer to.
And what do health funds rebate between?
Again, health funds, it depends on the health fund. So there's too many variables. Health funds tend to be like that. So some will rebate a lot, some practically nothing. But I think having that referral, the most important thing as far as health funds go is having that letter from the sleep physician. A GP will probably help, but they can be difficult sometimes to get the rebate if you don't have the right paperwork.
Here's another question that comes to mind. If a patient is, say, a truck driver and absolutely refuses to use a CPAP machine, and they have, say, moderate sleep apnea, there are regulatory obligations in this manner. How do you think a GP can move ahead with this?
Well, they would need to get clearance from you, wouldn't they, to get keep license. So then they would need to comply in some way. Otherwise, you're not obliged to. And for legal reasons, you shouldn't be writing a letter saying they're safe to drive if they're not doing something to help with their sleep apnea. So if they're not, and for them, you'd probably want to be doing repeat tests to make sure whatever device they're using, at CPAP or whatnot, is working, because it's quite a serious thing when you're driving long distances like that.
Thankfully, it would be up to the sleep physicians to do the authorization. I just think it would be such a heavy impost on GPs to do the right things without the right knowledge.
Yeah, and I think it's important for you not to feel pressured by them. I think some of them can be a bit pushy.
Now, I've already learned how to work with you all a little bit better. Are there different types of splints for different types of people, or just the one type?
Oh, there's different types of materials. There's splints that don't involve teeth. So for patients who have no teeth, they've got tongue retaining devices. So they just attach the tongue, like suck it out of their mouth. So there's a lot of options. And again, that's going to be a case-by-case basis, that sometimes we have to try a few different types because we might think a type works and then they turn out to be a very heavy clencher and they snap their splint in their sleep. So then we try a different material. So there's a lot of variables in that, and we'd probably talk to the patient case by case on that.
That would be a very expensive experiment, wouldn't it? Because each device would be $2,000 to $3,000 if it snaps it.
So dentists probably, most of them have their preferred device that they find works best, and then occasionally use a different one. But they're finding, especially the newer, the nylon 3D printed ones are pretty strong and quite cheap. So a lot of patients like them a lot better than the acrylic bulkier ones.
Do they cause long-term bite issues in patients who use the splint?
Oftentimes, yes. And that's something that we have to discuss with the patient before we go ahead and make them, because obviously you're changing the jaw positions, you're going to change the TMJ over time. We do have morning aligners that we can give patients. So in the morning when they wake up, they can wear their aligners, try and reposition their teeth. And they work for some patients. It goes down a lot to compliance. So that's something that it's part of their very busy mornings. They also have to remember to do this. So for patients who are willing to do it, they will work. What's interesting though is that these bite changes, which can be quite noticeable sometimes, are more of a concern for us than for them. All they worry about is, I have more energy, I can do more with my day, I'm enjoying my life more, and the bite changes they don't sometimes even notice them. But because we take records before we start, and then as we monitor them over the years, we notice these changes, we make them aware that that's going to be a highly likely event at the start, and then we monitor them and let them know how it's going. But most of the time they're like, I don't care. I can sleep better. It's fine with me. So it's more of a concern for us because we're so focused on teeth rather than the patient.
Would it cause advanced or premature TMJ issues?
It can do. And again, this is something that if they already have pre-existing TMJ issues, we probably wouldn't recommend this as a first-line treatment. We'd recommend the CPAP, even surgery, if it's a very severe condition, because you are going to change the TMJ position over time. What we would do, though, for patients who don't have any pre-existing conditions is just monitor it. So we monitor in the first few days to week to see how they're tolerating it, and then every 6 months, so they're regular checkups, and we just see how they're going. But usually if they're wearing the morning aligners and doing things like that, it's not as noticeable, but it's very difficult. What's hard for us is we can't pick it. We can't look at a patient and go, oh yeah, you're most likely to. It's a bit very variant at the moment.
Now, would I just go on the subjective improvement of daytime hypersomnia as the fact that the splint is working, or do we have to retest with a sleep study wearing a splint?
That would be the gold standard. But as you know, it's very hard to get in sleep tests just to diagnose for the first time, let alone repeat. So that is something we leave up to the sleep physician. So if the sleep physician thinks that they're on the borderline of severe sleep apnea, let's repeat this test. Usually that moderate category is the one that they'd want to repeat for. They are the ones that, that's not our call, that's usually the sleep physicians, between you and the sleep physician. But definitely, look, if we could repeat tests on everyone, that would be fantastic, because then we would know if it's working. Do we need to titrate it a bit more? You can do the level 3 and 4, home tests as just a baseline. Okay, your AHI is improving, so something must be working. The full PSG probably wouldn't be something that most patients would be able to get unless it's severe. But yeah, look, that's going to vary between you and your patient.
I'm just going to ask you now to really just summarize this incredibly interesting organization that you're now running and how it will help us as GPs forward, especially when we come to treating patients with sleep apnea.
Firstly, if you've got a dentist referring to you, I would say, so you have a patient that you suspect has sleep apnea and you want to know, who do I refer to for this mandibular advancement splint, because you think that's an option at least. If you got that patient from a dentist, because we can't refer to a sleep physician, we have to refer to a GP. And one of the issues that dentists have at the moment is that we find not all GPs are well versed in sleep apnea. So we pick up these issues because there are dental signs of sleep apnea. There's teeth grinding. They're falling asleep in our chair. We have these clues that they might be suffering from that. They don't come to us and say, I snore, I have sleep apnea, can you help me? They come to us with teeth issues. So our issue is we then do a bit of investigating. We might run some sleep questionnaires, and then we refer to the GP. We're relying then on the GP to progress that forward. So our biggest issue right now is not having enough GPs who understand it or move that forward to a sleep test. So that's the first thing. So we need a good working relationship with our GPs. If you're getting a referral from a dentist and they've done, an ESS or an OSA 50 and they've told you about their BMI, and you can tell that this dentist knows something about sleep apnea, I would, if I was a GP, refer back to that dentist if you're going down the pathway of referral. If you've got a patient just walking into your surgery for some issue and you or suspect sleep apnea, send them for a test, they come back with sleep apnea and they need a device, that's when you can go on the FDSM registry and find a dentist in your area if you don't have one that you regularly work with, and then do the pathways that way. So the FDSM, the Fellow of Dental Sleep Medicine, it's a certification program. So dentists who have worked with a lot of patients with sleep apnea, they have to present case studies, they have to do a logbook, they have to go and observe in a sleep lab, they have to do an exam. There's a lot of hoops to jump through to prove their competency in this area. So if you go onto the registry and you find a dentist on there, you'll know that they have proved themselves. They've worked with patients, they know their research, so they're reliable dentists to send to. And that's what I'm managing at the moment, this program. So hopefully that will help GPs find a suitably qualified dentist if you don't have one that you already work with, and also for patients. So maybe patients coming from a bit far, the registry will have dentists listed by states and suburbs. So hopefully that will help you as well.
What I've learned from you is that if I am therefore to refer to a sleep physician, I will insert a paragraph to ask if a jaw advancement splint is an appropriate form of treatment. The second thing I've learned from you is that I will inform the patient that if they are thinking about an alternative, that one is a gold standard, less tolerated, one is less effective, better tolerated, in the end, similar sort of efficacy. But it is the lifestyle change that is hugely important, and not to rely on any one therapy to fix them.
Absolutely.
You've also told us that it's probably up to not us, maybe to you, to look for changes in bite.
Yeah.
Patients may observe it or they may not care about it. In the long term, some of these patients may develop some TMJ symptoms, but it's hard to tell whom. But because of this, patients with pre-existing TMJ issues should not be advised to use a splint. Have I got this right?
At least not as a first line therapy. So maybe look at that, because because CPAP's difficult, it might be an option if CPAP absolutely fails. But yeah, so it's patient selection, even for us, like we wouldn't be choosing the obese patient with bad TMD as your best patient for this.
Absolutely. And you know what I've learned? I've learned that if I had a very obese patient already using a CPAP machine and still feeling tired, and they don't have a TMJ issue, I'm now thinking maybe I should also throw in a jaw advancement splint for those particular patients, something I've never thought about before.
Combination is actually probably a little bit more effective. And then at least you've got a backup. One thing comes out in the middle of the night, and at least something else is continuing on.
It's been a very interesting conversation with you, Dina, and I thank you for telling us about the good work you're doing with your association. I never knew of its existence.
Oh yeah, you can see.
You will send us I'm hoping you will send us a link to your association so I can attach it to your podcast.
Yep, no worries. I'll send you the link to the ASA as well as the link to the registry. We've only got the first few candidates coming through this year, so there's not going to be anyone on it till probably towards the end of the year. But yeah, hopefully you'll have quite a few dentists to choose from as they go through.
I'm really grateful I've spoken with you. I've learned much, and I wish you a very good day.
You too. Thank you.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.